Hello, everyone. Good evening. This is Dr. Shaher Khan, board-certified plastic surgeon. Pleasure to come on tonight and discuss again what is a very important and a hot topic. And hopefully you find this very informative. I'm going to go ahead and wait a couple of minutes to let the audience join. Again, this is Dr. Shaher Khan. I'm a board-certified plastic surgeon, certified by the only one and authentic board, which is the American Society of Plastic Surgeons, that certifies plastic surgeons and authenticates them to be trained and to also have the right professionalism such that we can provide the best services to our patients. I'm also a board-certified general surgeon, 5 years in training, and then I also did 2 years of burns critical care training, taking care and managing a lot of sick patients, especially the burn patients, especially the critical care aspects. So a total of 10 years in the process. So having said this, my practice is exclusively devoted 99% to explantation, that is removal of both silicone implants and saline implants. And this is basically where I give talks and basically raise awareness, and something very similar what I'm doing tonight. I'm going to go ahead and hopefully answer a lot of questions that many ladies have, such that you become get that informed consent such that you feel comfortable signing up with your surgeon. And remember, this is the most important thing. One of the most important aspects of explantation is to have that confidence in your plastic surgeon that he or she is going to do the right surgery. The first and foremost, just a 10-15 minute introduction, and then I'll go ahead and jump straight to the questions because I have a lot that I need to answer. The first and foremost is your surgeon must accept that breast implant illness exists. I have had patients that went to some surgeons that they said, well, breast implant illness truly doesn't exist, or it is basically a myth. You would never get the right surgery from a surgeon who would not accept or believe in it. Now, if you're not going to believe in an illness, you're not going to know how to treat it. The second thing is your surgeon should have a track record. On social media nowadays, everyone has a track record where you should feel very comfortable talking to the previous patients of that surgeon, so that you kind of get that feeling of confidence that your surgeon is truly committed to removing not only the implant, but also the capsule and all inflamed tissue. Because if that is not done, then your surgeon would inevitably be doing what is the incomplete surgery. And this is where you will not recover. Yesterday, I talked to a 37-year-old nurse, for example. She had her explantation done in 2020, and post-op, she continues to have the same set of problems. Now, she knows, because of the many other ladies that she has talked to, that she has the residual capsules. She is not on any medication other than a weight loss medication, and that she's otherwise healthy. And she has 28 of those symptoms out of the 55 where she knows deep down within that she has the residual capsules, because her surgery was done in an hour and a half. So she has all the red flags. You do not want to be this patient, because that is, quote, the worst case scenario. She informed me she has already spent almost $25,000 worth of workup, kind of making sure she doesn't have the other illnesses, and having gone an explantation. And now she has to undergo what is a residual capsule removal, because her first surgery was not done right. Her surgeon basically took her to the operating room and reassured her that he was going to remove the capsule. And when the going gets tough, and when the surgery basically gets involved, and majority of the cases where the implant is below the muscle, that thin capsule becomes a challenge for the surgeon, and he or she is then not committed into what is doing a complete surgery. So very important to talk to your surgeon directly, not to talk to the physician assistant or the nurse practitioner. You should have that legal bind on the consent form that specifically states that the goal and purpose of the surgery is end bloc explantation, which is removal of the entire implant capsule plus all inflamed tissue, and that it must be tested for the BII, LCL, the lymphoma, malignancy, abnormalities, It should be checked for cultures, aerobic, anaerobic, and fungal. The implants must be returned to you. And again, as you will see, a complete, detailed, comprehensive workup such that post-op you have that peace of mind that your surgeon did the right surgery and that you have nothing negative and all the badness, if you will, the malignancy cancers have been ruled out. Now, what I'm going to go ahead and do is I want what I'm going to do next is I'm going to go ahead and answer some of the questions, and hopefully I will go ahead and answer each one of them as they come. So having said this, I will go ahead and read. We had asked the ladies to go ahead and submit the questions such that I could answer each one of them. These were very interesting questions. I've had a podcast as well where I have, on a weekly basis, my nurse Caitlin and I answer questions. So hopefully you find these informative. These are 20-30 minute question answer sessions as well, where I answer questions related to a certain aspect. Please look at the couple of Zooms that I have done. One in March, earlier this month, 2023, and then one in January, where you can see a lot of questions I have answered and the way how I do it. Now, what's amazing is you go to 10 different plastic surgeons, without a doubt, you're going to get 10 different answers, 10 different approaches. Now, we're looking at explant surgeons, primarily. Majority of the plastic surgeons don't want to even hear the word breast implant illness. There is a general acceptance in the world of plastic surgery that breast implant illness does not exist, that these implants are safe, and that the BII is a very rare phenomenon, which is absolutely incorrect. As you will hear me say this, eventually all breast implants will need to be removed. They're not meant to be in the body forever, and they're replete with problems. So if I may highlight, the FDA has mentioned that the breast implants are not meant to be in the body forever. These are, again, the FDA recommendations and warnings. Number one, breast implants are not meant to be in the body forever. They last anywhere from 10 to 15 years. I say they last anywhere from 7 to 10 before they start giving problems. Some sooner, some later. But this is pretty much the norm. The second, that breast implants are associated with breast implant-associated anaplastic large cell lymphoma, also squamous cell cancer. And this number is underreported because not many plastic surgeons are sending the capsules. The third thing that the FDA mentioned was that breast implant illness indeed does exist. Joint pain, psychological issues like anxiety, depression, GI autoimmune issues, among many others, exist, and that there is, quote, complete resolution when the implants are removed and not replaced. As you will see, the manufacturers themselves, when you listen to that Zoom, they themselves highlight the many detrimental effects of breast implants. So having said this, I'm going to go ahead and get started with my first question. Do you see more illness with patients who have thin capsules with a gel bleed? Very good question. So I have seen problems. So let's look at the history. In 1992, silicone implants were banned. I will tell you the FDA faltered in that, made a mistake. They should have banned saline implants as well, because the saline implants cause the same set of problems as the silicone implants. And if I have 100 patients that present to me, and they present their symptoms, I will not be able to tell if they have saline or silicone. And as you will see in the many Facebook Lives that I have done, patients with intact saline implants also have this gel bleed phenomenon, where if I go touch the implant right after I've removed the capsule and I separate my hands as far as when I'm wearing the gloves, you will see that gum sign where you will see that gel bleed clearly visible, which is consistent with the silicone leaching from an intact saline implant where the silicone shell is present. This will occur in saline implants and certainly silicone implants from day one. And this is what Dr. Henry Dijkman out of the Netherlands has shown, that this is truly the case. This gel bleed phenomenon will occur even in thin capsules and certainly thick capsules. And we know this for a fact. Some ladies are able to wall off and form a capsule that's thicker. Some ladies will form a capsule grade 4, for example, where it's painful and thick, hard like a rock, maybe on the right side, and on the other side will be nice and soft and normal appearing. Why this capsular contracture occurs? There are many reasons for it. Capsular contracture can usually occurs when the implant is placed above the muscle or if it's a larger implant. Majority of the times we do not know why it occurs. Sometimes there are bacteria that are in that biofilm / colonization that cause this capsular contracture to occur. Textured implants cause more inflammation, hence more, but there are many reasons why capsular contracture occur, and these are some of the reasons. Majority of the times we do not know why it truly occurs, why it would occur on one side versus the other. So a thin capsule needs to be removed as much as a thick capsule, and you cannot visualize by looking at the capsule and say, well, it is benign appearing. Oh, as the surgeon, I have heard many times say, you can leave the thin capsule behind, or I chose to leave the thin capsule behind because it did not look pathologic. That's absolutely a no-no. You cannot look at the capsule with the naked eye, i.e. grossly, or even with the loop magnification, which is usually 2.5 or 3.5 times magnification, and conclude. You have to look at the cells underneath the microscope with 100 or 250 time magnification with appropriate stains, and then only then can the pathologist conclude if it was a giant cell reaction, histiocytic reaction, and so a thin capsule needs to be removed as much as a thick capsule, and saline implants are as bad as the silicone implants, and gel bleed phenomenon occurs in saline implants as much as the silicone implants. And as you will see, if you go look through my private breast implant illness support group page, I took a set of implants from a nice lady who donated them, and I sent them to Dr. Henry Dijkman in the Netherlands. He took the saline out of the saline implant and centrifuged it at 1,000 RPM for an hour, and at the end collected what was a sediment of what is silicone particles, and you can see that if it leaches into the body, it certainly is leaching, and this is basically why I sent the implants to show. Now this is one set of implants. I will tell you, this is not a secret that manufacturers themselves also mention and discuss the gel bleed phenomenon, and this is, remember, the root cause of the problem. So saline implants, there is no such thing as an excuse. These were thin capsules, so the plastic surgeon decided to leave them. No, they need to be removed as much, and they need to be removed off of the rib sincerely, definitively. We know, again, the many cases where the partial capsule was removed and some of the capsule, 10-20% directly on top of the rib, was left behind, and now the patient continues to have the many signs and symptoms till all of the capsule is removed. And this is important, all of the capsule. This is, remember, the gist and heart of the surgery. You should go to your plastic surgeon and ask one question: how committed, how devoted, how sincere are you? What is the goal of the explant surgery? And he or she must answer with absolute firm faith that the entire capsule must be removed along with the implant plus other inflamed tissue around. Because remember, the gel bleed phenomenon occurs where the tissue around also harbors the silica. And it is important to remove all of that, because if any of that tissue is left behind, the patient might improve 60-80%, and she might think that this is the benefit she was looking for, whereas there was another 20-30% or so. Because clearly we know this for two reasons. Number one, the many pathology reports, you will see the capsules will highlight that there was multinucleated giant cell reaction, histiocytic reaction, there was chronic inflammation, and this was a reaction to silica. Look at the last couple of videos from almost a week ago, from the first and second week of March, where I go and discuss the pathology reports. So that is proof in itself that the capsule must be removed. And number two, you look at the many patients who have had their capsules left behind, and now only when the residual capsules are removed do they bounce back to a normal state of good health minus the toxins. If I may, on the 12th of April, I have exactly just the same patient that I'm mentioning. She, and amongst the many other patients with the residual capsules, where she went and sought confidence in a plastic surgeon who reassured her that she would remove the whole capsule. And she was given an operative note telling 100% total capsulectomy was performed along with the implant, and she did not get better. And she knew better that this is not her, that she's still hurting, and that she still has the many signs and symptoms of breast implant illness. So she came to me, I operated on her, I removed the residual capsules, and you will hear from her own words how she feels now compared to what she did after removal of the implant and partial capsule removal. So this is again very important to remove all of the capsules sincerely. Remember, this is the gist and heart of the whole surgery itself. Can a thick capsule protect more? So that's a good point. See, the body itself is very smart. Sometimes some patients have a ruptured appendix, for example, and you will see they're very sick. They get a temperature of 103, 104, and they're like deathly sick and ill. And all of a sudden, day 3, day 4, they wall off this abscess, which is the appendix rupturing and ruptured, and it walls it off and it forms, the body itself is very smart. Now, there are times where the capsular contracture occurs and it can only protect so much, especially in the older implants or even the newer ones. Some ladies, for example, as you will see, they had implants just 6 months ago, and you look at their, examine their chest, it's hard like a rock, and you would think that she would be protected by that hard capsule. No, it's not, because the body itself is trying to protect this leaching phenomenon, but the silicone itself, it's finding a way to travel into the bloodstream. Now, we know this because, again, if you look at Dr. Henry Dykman's studies, where he did biopsies on a patient that had passed, and also Dr. Atul Mehta out of the Cleveland Clinic, again, Atul, last name Mehta. He's a pulmonologist out of the world-renowned Cleveland Clinic in Cleveland, Ohio, the pulmonology department, the Heart and Lung Institute. He did a biopsy of a lung specimen on a patient who had shortness of breath and ground glass opacities on a CT scan. And lo and behold, this lung tissue sample was then biopsied, and then analysis was done to look for foreign material, and a lab out of Buffalo concluded using electron microscopy, number one, and number two, energy dispersive x-rays, that this was indeed silica within the lung. And as Dr. Atul Mehta very well mentioned, this traveled via blood into the lung tissue, causing this lady a lot of discomfort and the shortness of breath and respiratory compromise and decline. And so this is clearly that occurs. So a thicker capsule will certainly try to protect, but not enough. And the ladies themselves, as you will see, and here they will present with the many signs, symptoms of what is silicone toxicity. As you will see in the many patients with ruptured implants, even non-ruptured implants, you will see they have palpable lymph nodes, where even despite thin or thick capsules, they have biopsy proven silica within their lymph nodes. Now, everyone doesn't get them, but eventually everyone will, because remember, it is leaching into the blood. Some are able to protect it better, some are not. And you find, for example, some patients within first week, they start reacting to what is breast implant illness. If you go back and look, there was a 22-year-old lady a year ago that I did, approximately 22-year-old. She had implants. Within a couple of weeks, she was at the emergency room. She came and saw me at the third week, and on day 29, I explanted her, and lo and behold, the 15-pound of weight loss because of her GI disturbance, amongst with the tingling numbness in the arms and legs, all of that resolved, and it was a clear association of what is the silicone toxicity as a result of intact silicone implants that are started reacting in her very soon. And you will hear the many patients that will state that ever since they got their implants, things have never been the same. Now, next question is there a diagnosis code for B2 yet? Unfortunately, the insurance companies, including Medicare, they do not recognize breast implant unless there is no ICD-10 code. Now, there is mention and recognition of the detrimental effects. There's ample evidence about lymphoma, about, look, the FDA warning, the warning number 3 that I mentioned, that patients with joint pain, autoimmune issues, scleroderma problems, they have had complete resolution of their symptoms, quote unquote, complete resolution. Now, they're telling you that it does exist. Why is it that they're not putting forth an ICD-10 code? It will only be appropriate, right, if you mention. So this is where I request all my listeners to write to the FDA, to write to their senators, to the governor, and and literally this is how we bring about change. It's certainly at a snail's pace, but we need to document the detrimental effects so the appropriate societies. Now, 5 years ago, no one had even heard of breast implant illness. Look where we are today in 2023, March of 2023, and hopefully with time that this becomes a recognized entity and the patients don't have to pay out of pocket because this is essentially what it entails for the patients to get the right surgery. If your surgeon is doing a surgery in an hour and a half, taking your insurance, I tell you 100% your surgeon is not removing the entire capsule plus the implant plus all inflamed tissue. I myself, I take 4 hours approximately to do this surgery. I would love to do it in an hour and a half and do 6 or 8 of these in a day. I will tell you I cannot do but max 3 in a day. And this is where I book each and every patient for approximately 4 hours so that I can do the surgery. And majority of the times, I run over the 4 times just so that I can offer 100% the best. Because you never know, I never know how the case is going to go, if the implant is ruptured or not, what is the extent of the dissection off of the rib. Sometimes even small implants, for example, 250 cc's, the way they are placed, depending on how good their initial surgeon was, certainly can pose a challenge versus another set of implants. If they're above, that is going to be the kind of the better case scenario. So in my practice, I have noticed that a lady with saline implants on top, one set with the grade 4 contracture, 125 cc implant is the best case scenario that I will ever have, where I know there is no dissection on top of the rib, there is no 800 cc implant that I have to remove, there is no inflammation, for example, there is no rupture, and I know things will be relatively straightforward. So the worst case scenario is many patients who present with multiple surgeries, a set of implants above, a set of implants below. Now I have to remove the other respective capsules that were above at one time because they need to be removed as much as the implants when they were placed underneath the muscle. And ruptured implants where I have to remove alloderm sometimes or suture material, especially in the cancer patients. So those are the more complex patients. And this is where on a Wednesday I would do 2 cases because these can take 5 hours approximately or so. Can a clinical diagnosis be given and surgery covered by insurance? Now, so this is very important. Insurance does not want that. Now, this is a fact. And any person who works in the hospital system, be it a doctor, a nurse, nurse practitioner, anyone, you will see the medical system in the United States, unfortunately, very boldly, is a failing and a failed system. The insurance companies could care less. They deny cases without opening the charts. We know this. There are incentivized ways of insurance companies to give doctors money so that they're not referred to specialists. That's established fact. Number 1 reason for bankruptcy in the United States is medical bills. Number 3, the doctors themselves, if you ask me, truly are not committed. The general practitioners, the OBGYNs, a vast majority, well over 95%, if not more, are not even wanting to accept breast implant illness. Now, the insurance companies say, well, we're not going to cover unless you have grade 4 contracture or rupture. Even when they do, they say, who told you to remove the capsule? Because that is not part of the requirement. Now, this is where the insurance companies would only reimburse a fraction, maybe $600, $800, $1,200. One patient, believe it or not, got reimbursed $17 because of the contract she had with her insurance. Now, this is any doctor who takes, any surgeon who takes insurance to remove the case, 100% is going to do an incomplete surgery because you cannot justify 4 or 5 hours of surgery and only get reimbursed $600, $800, $1,200, which is pretty much the norm if you get reimbursed. And so this is basically a fact and firm. There is no denying the fact. Unfortunately, there have been times where the insurances deny the cases. For example, the ones that I have to do at the hospital. For example, today I did a case at the hospital. This lady was 40 years of age, and she had an MI, a heart attack at age 40. So I had to do her at the hospital. You would be surprised, again, we have to get the clearances. We have to make sure that the surgery is authorized because it's being covered at the hospital. And there was once a case, for example, that got denied literally the day before, which is how the insurance companies do. And the next thing you know, they actually sent what is a pediatrician to challenge the case. And when I did ask him, he had never even heard of, let alone, how to manage what is explantation. It was very interesting when I asked him about, breast implant illness, and he told me that he wanted me to give him data to support whatever I was doing. And I told him it was his responsibility as an agent for the insurance company. And this kind of tells you the shame that unfortunately the government is very passive about it. The insurance companies could care less. Majority of the doctors, if you ask me very professionally, I use the word, this is not their specialty. If you ask me about, managing endocrinology, like how to treat diabetes or blood pressure or rheumatoid arthritis or lupus, for example, or multiple, I will tell you this, I have no idea. I have no expertise in that. And likewise, I wouldn't expect them, i.e. the doctors, to know about breast implant illness and to be very well versed on what is a very, quote, I use the word hidden topic, but hopefully as more and more awareness is made, that they become knowledgeable about a real problem with a real entity. So write to your local authorities so that you can raise awareness, and hopefully an ICD-10 code is given and the patients benefit from this. And I will tell you, the insurances nowadays don't pay anything for any surgeries, even like for example, a knee scope or a colonoscopy. For example, the colonoscopy Medicare reimbursement is approximately $207. This is just a screening colonoscopy without any polyp removal, just to go in, and then tells you that's nothing. And just like with an explantation, for example, and you can look this up. So there is no code. The codes that I use every time I do a consultation, especially when I myself review all the cases, I write down breast implant illness, especially when I review the many signs symptoms that the patients present with. I write down essential surgery, non-cosmetic in nature, and then the patient's desire for removal of bilateral breast implants. In the middle of COVID, for example, this is when all the hospitals were shut down. I took my patient, for example, the one with severe pulmonary hypertension, Monday morning, 9 o'clock, when the entire hospital was shut down and they were doing only emergency surgeries. Not even rotator cuffs or knee scopes or things like that. I was able to get time, prime time, Monday morning, 9 o'clock, because the hospital understood that I am only doing this for the patient's best health. And so this needs to be documented as such. And I make it a point that we're doing this for the patient's best. This is, if you think about it, the most non-cosmetic surgery that any patient will have. And so this is where we're trying to get her life back minus all these symptoms. Just like that 37-year-old nurse that I talked about earlier, she has the residual capsules. She's coming to me to remove her capsules because she knows, and I know, that she has the 28 sign symptoms. She's hurting. She cannot function. She's very fatigued and not able to think with the brain fog and not able to do her day-to-day responsibilities. And she has to make that move in order to get that residual capsules. And you will hear from her, and we will see again, hopefully she comes forth and discusses her story, just like the lady on the 12th of April, where you will see the residual capsules are, quote, the worst case scenario for the patient because now she has to undergo a second surgery. Now, next question. Can a primary care doctor or other specialist diagnose BII and refer to a plastic surgeon? So again, I kind of answered this question. So the plastic surgeon primarily is the one who is, I would say, better able to diagnose and rule out. Because remember, this is a diagnosis of exclusion. There is no lab test. There is no CRP, which is the inflammatory markers or ESR, which are very generalized inflammatory markers. There is no lab workup. There is no imaging modality. There is no true diagnosis where one can say, all right, you got this. For example, someone has diabetes, for example, a hemoglobin A1C of 8. You can say by definition that is diabetes, right? Just from that one lab value, there is nothing. So this is where I tell my patients, there's a patient that I saw, she had never been to a doctor for 20 years. I said, you have to go to the doctor. You have to get your thyroid checked. You have to get your adrenals. You have to make sure that you go and get the series of labs just to make sure that everything is negative. And essentially when all of that is ruled out, i.e. hypothyroidism from Hashimoto's, for example, or an adrenal state where the patient has adrenal issues, for example, or severe depression, right, amongst many other problems. Now, I can look at and get a good idea and sense of the patient's severity of the breast implant illness by looking at that questionnaire where the patient states, and she checks off the boxes or circles what are her complaints. So for example, this is the brain fog, fatigue, joint pain, GI disturbances, anxiety, depression, feeling like she's dying, rashes, hair loss, dry skin, eyes, throat trickling, for example, neck and back pain, fibromyalgia type symptoms, autoimmune issues, tinnitus, vertigo, the head spinning or ringing in the ears, the many problems with, for example, chest pain, shortness of breath, amongst the many others, tingling numbness in the arms and legs. Now, if I have, let's go back to that 37-year-old lady. She had 28 of those symptoms checked off, and she has residual capsules, and she has what is BII, breast implant illness. Now, I ask the patient sometimes, what % chance do you think by looking at the symptoms that you have breast implant illness? What's very interesting and ironic, the patients majority of the time say 110% that they have. Now, what is very interesting is here you have the whole world of plastic surgery saying breast implant illness is a myth, right? It doesn't exist and it only afflicts a small fraction. And here's this patient basically making a definitive diagnosis. Now, I tell the patients, well, there's two things you have to do. Number one, do nothing, pray to God, or keep taking the steroids or putting a Band-Aid on, or taking Plaquenil or whatnot else, what the patients get. For example, the patient that I'm operating tomorrow, nice lady from New York, she had arrhythmias, now very well established. Now she's gone to the doctor, she's been, Holtered, meaning the Holter monitor has gone on, the echo and everything else, and they have said, well, here's a medication to slow your heart rate. Now we know that once the implants are removed, because we have a lot of other patients that state that they have had these irregular heartbeats. Now all of this is pointing towards that this is BII till proven otherwise. Now remember, no one walks into my clinic and says, well, my implants are making me healthier, I can think better, I can jump faster, and higher. If anything, the opposite. The implants ultimately only hurt the body. And so this is where the diagnosis of exclusion is made. And once the entire implant capsule and all inflamed tissue is removed definitively, then we can point with certainty. And as you will see, well over 90% of the patients are benefiting and improving on their quality of life once they have explanted, especially when done right. Now, this is very important, when done right. Now, remember, there are a lot of plastic surgeons who are doing the surgery. There was another patient, she stated, well, my plastic surgeon, he's still augmenting, and he put down on his website, he's an explant. I will tell you, everyone is going to start to capitalize on this if this is what they have to say and to be politically correct. Of course, I believe in breast implant, unless if this is all what it takes to get another patient, why not? Because remember, medicine in the United States is a big business. There are stents in the heart that are placed on patients that do not need a stent. Just ask any cath nurse and you will get the answer. You ask any aspect of medicine, you will see is a business for the hospital. The hospital's in this to make money. And I'll tell you, the biggest business of medicine is plastic surgery and dermatology, because these are the cash patients. And this is where you have to have good marketing, if you will. And this is all what it takes, some good convincing, and the patient will do whatever you want. And unfortunately, this is where majority of the patients with breast cancer and many of the other young ladies who are, quote, sold on the fact that the newer generation implants are safe, unfortunately decide unknowingly, without informed consent, proceeding with what is a whole series of problems that they have to deal with later in life, sometimes 5, 7, 10 years later. So going back to the point here is you have to have that the diagnosis of exclusion where all of that other bad organic causes are ruled out, and then we can point the finger towards what is breast implant illness. And when done right, you go to 10 different explant surgeons, you will see 10 different answers. Everyone's using a drain. I have had many patients that came to me and say, how come you don't use drains? I say, just go to my YouTube videos, Facebook post, and see, I have many operating room videos, and look at many of my patients who have their videos and their post-op chest videos, for example, and you'll see the vast majority of the ladies don't need the drains, and surgery absolutely can be done safely. I have no problems about putting in drains, but guess what? Majority of the patients do not need. I have not put in drains in any of my saline patients. I've not put in drains in on most of my ruptured silicone patients, because I've been able to remove all of the badness, i.e. all of the silicone and that the peripheral tissue where the silicone has leached into, because that has given the patient the best chance to bounce back to a normal state of good health. You cannot grossly look at and leave behind tissue that might be bad. You don't want the patient to be hurting. And remember, look at all the tissue that I removed. It is pathologic. It is abnormal. Having been in the operating room and operating since 1998, I can tell, just like we all surgeons, which tissue is good and which tissue is bad, which tissue needs to be left behind and which tissue needs to be physically removed and sent to pathology. Because again, grossly, the eyes cannot look and conclude that this is healthy or bad. Only under the microscope can we tell. And in this surgery, when, for example, someone gets a tummy tuck, we know that is good, healthy abdominal tissue, right? In the breast tissue itself and our periphery, that is all inflamed tissue. All one needs to do is look at the many symptoms of breast implant illness. Remember, this is the epicenter of the badness, the inflammation, the dilated veins, right? The pain and hurt and the irritation, the redness that is present. All of the symptoms that you see, the gel bleed and the local phenomenon, all of that tissue is there. And this is where that leaching is occurring. Going back to the first question, the gel bleed. All of this tissue needs to be removed, because you don't want to be doing the surgery and leaving behind this inflamed tissue and now removing the thinnest of the capsules, and that inflammatory burden was left behind because there was some extravasation of that gel bleed phenomenon into the periphery. So hopefully, so now as you will see, the other thing I want to highlight is, look, I make an incision that is horizontal right in the crease, and I mark the patients. I see them, I discuss with them in pre-op. I myself mark the right and the left side, and I tell them exactly where I'm making the incision, and it's always horizontal, because I don't want to go and cut up and down. Number one, you're leaving a scar right in the center of the chest. Number two, you're cutting around the nipple areola where the nerves and ducts are cut, inevitably, in order to make that cut up and down. The up and down cut, this is the most important point, will not allow for a surgeon such as myself to cut parallel to the rib, and the exposure will absolutely be compromised in an up and down cut versus a horizontal cut. The horizontal cut allows me to go parallel to the rib, which is where I'm able to safely, definitively, completely remove the whole capsule off of the rib, all the way from the medial side to the lateral and all the way up. Remember, when the implants were once placed, they were not too far away from where the clavicle sits, because that is, quote, below the muscle dissection. And that's where the breast tissue extends still. So this is a vast area. Eventually, over time, 5, 10, 15, 20 years, the implants only start to go down and out just because of the bottoming out and the gravity effect. And so the point I'm trying to make here is the up and down incision does not allow for me, number one, good aesthetics. You compromise the nerve duct, and sometimes you're cutting directly to the breast tissue. And then you're not able to, one is not able to see clearly the capsule directly on top of the rib and dissect all the way from the medial side to the lateral side, which is, remember, the whole gist of the case is to removing the whole capsule. Now, next question. Why is it unsafe to leave ruptured implants in the body? Now, this is a no-brainer. And I use the word, no-brainer. I don't want to be... remember, silicone is not supposed to be in the body, right? Look at just the ingredient list, i.e. what is the chemical composition, from platinum to all these heavy metals and God knows what else, right? And that's slowly leaching into the body. That's truly like poison. We know this because just look at the capsules. We know the chronic inflammation, multinucleated giant cell reaction, histiocytic reaction. Look at the many ladies, for example, we hear about who get industrial grade silicone injected into their chest, buttock area for enhancement. This is obviously in Florida and New York quite a lot, which is illegal. You see the silicone granulomas that form. In many of my patients where the silicone has leaked out, you see patients with silicone granulomas. You see fat necrosis as a direct result of that silicone. Remember, silicone is very, what's the word to use? Caustic. It hurts and harms the good cells. It is a unhealthy, very reactive foreign material that causes, quote, silicone mastitis. Silicone mastitis. Mast means breast tissue, mammary tissue. Itis means inflammation. So this is for someone to say, so this happened. This was a consultation I did 10 days ago on a Sunday. This one nice lady, she goes to her own plastic surgeon and she has an MRI that was ordered that shows 5 years ago that she had a ruptured silicone implants. So her plastic surgeon amazingly says, so what? Live happily ever after because your result looks good. And this is the silent rupture. Majority of the ruptures are silent ruptures. She's like, it doesn't make sense. Look at the manufacturers themselves and the FDA. What did they say? Now, Mark, everything that I say is, very calculated, and I am very careful in whatever I say, because I don't want to mislead, and I want you to fact check every single sentence that I've said. The FDA and the manufacturers themselves, that is Mentor and Allergan, state this. If one lady has implants, at year 3, she should get her first MRI, and then every 2 years there onward to look for a silent rupture. Now, they mention in their catalog the implications behind a silicone leak is undetermined. Now, don't tell me it's undetermined. I'll tell you this. It is harmful and bad. Look at the chemical composition of the silicone implant. So it absolutely has to be removed. Look at the many ladies with even ruptured saline implants. They have silica that is there and that's causing a lot of hurt. Why would they want to get an MRI? Because they want to get it out, right? This is the problem. This is just like saying that keep checking for badness because you want to get it out if it's ruptured, right? Otherwise, why would they tell you to get an MRI every 2 years after the 3 years, meaning at the year 3, and then every 2 years they're onward, right? So, for example, if a lady has implants for 10 years, she should, according to the guidelines, right, get an MRI at year 3, at year 5, year 7, and year 9. So that's 4 MRIs. And guess what? Only 5% of the population gets MRIs because the insurance says, who told you to get these? Everything is kind of on your own, and no one wants to even cover this, and the patient has to cover it. And unfortunately, many of the patients are told you will live with the implants forever, which is absolutely incorrect. The FDA even highlights that they're not meant to be in the body forever, including the manufacturers themselves, Mentor and Allergan. And this is another take-home message. Someone asked me this, well, everything looks great. Why should I take them out? I think this looks phenomenal on me. I said, today it does. Can you guarantee me tomorrow they're not going to rupture? Next year, the year after, 3 years, and now you're going to have that silica that's going to leak, because now, as you will see, Dr. Henry Dykman, and clinically as well, a ruptured implant will leak, ooze, and cause more of the silicone, because it's not protected by the intactness of that silicone implant, will cause more of that silicone to move and leak and leach around versus an intact silicone implant, right? So a ruptured implant is worse as far as dissipating and leaking the silicone. Why do you want to deal with a bigger fire and a rupture and pain and misery and inflammation and that worsening of the process of silicone leaching into the lymph nodes when you can contain the fire initially early on, right? And so this is the same thing, right? Textured implants, they're banned. I will tell you, if I know I have textured implants today, am I going to be okay with it? Am I going to be comfortable with the thought that they're associated with BII, a proven cancer that's directly associated with implants? Meaning, had the lady not had implants, she would not have had the BII. And the answer is, I would feel very uncomfortable because I don't want anything that's even remotely associated with BII, and especially when they're telling you, both the manufacturers and the FDA, that the number is way underreported, and now because of their warnings that they have put forth, more and more patients and awareness is occurring. So better to take care of a small fire versus a big fire, which we know inevitably is going to occur, right? Now, this is also a very important topic. I've not touched much upon this, and I want you to, this is your homework, each one of you, and you can do it. It doesn't take much, but I'm going to go ahead and paraphrase. If you look at many of the manufacturers, that includes Mentor and Allergan, by far the two most common, not Sientra, they themselves look at their leak or rupture rate, not the leak, but the rupture rate. So what is the study, what are the studies that have been done to look at Mentor breast implant silicone and Allergan silicone implant rupture rate? They will tell you they look at 6-year mark. Why do they stop at 6? Allergan stopped at 10 years. So they have data up to 10 years. After 10 years, they basically are not. And then even then afterwards, they assess by ultrasound. Remember, ultrasound is a very crude, inaccurate, not precise way of looking for what is a rupture. MRI is another study or modality along with the patient's questionnaire back and forth. Now, you cannot tell 100% if it's ruptured or not till you cut open the capsule, right? So they do their studies up to year 6 and year 10. And this is, why do they not go up to year 12, year 15? And I want you to do this. So if there's one thing that I want you to look up today, it's this one. What is the maximum length of time that the manufacturers themselves have looked at silicone implants, be it Mentor or Allergan, and what have they concluded as far as their, quote, rupture rate? Meaning, what is their incidence of rupture? And you will see after 6 years for Mentor, 10 years, there is no data after a certain period of time because the rupture rate goes up exponentially and they don't want to scare away the many prospective patients who are going to be getting these implants. And this is the scary part. So if you have a good exam, good for you. You may have a silent rupture. There's a lady that I took care of. Remember, I said this earlier. Majority of the ruptures are silent ruptures. That's why their FDA is telling you and the manufacturers are telling you, go get an MRI to look for a silent rupture. Everything looks great, but guess what? You have a silent rupture. I saw a lady this week on Monday, 3 days ago, and she had a 2011 set of implants, both ruptured, right? You don't want to be taking care of a rupture and potentially having silicone leaching into the lymph nodes and the periphery, or making, I'll tell you, there's no guarantee that when I do her surgery that the silicone is not going to, quote, be free floating when I make the incision, which has happened before, and those patients absolutely got drains. And I'll tell you, once the silicone goes into the chest, it spills into the chest, inevitably the drain is mandatory, and any inflamed tissues left behind, because then it's going to weep, right? We want that to collect out. Remember, another good sign of a surgeon, and I'm hearing more and more some of the surgeons now are doing explantation when done right, where they're not using drains, and good for them, which gives me that confidence that surgeon did an excellent job with the explant, meaning did the total capsule removal, and there was no silicone left in the chest because no drain was used. So going back to the point here, the rate of rupture is very real. The data is very premature, 6 years, 10 years. There is no long term. And why wait for badness to occur when you know you are in control now? You don't want to be in a position where you have a rupture or unknown rupture and you're living with the badness, and you think that everything looks good because it was a silent rupture. Now, next question is, when you do an end block, do you also remove tissue around the capsule more so than other surgeons, or just the tissue needed surrounding the capsule? So, no, this is a very good question. So in the vast majority of the patients, the implant is below the muscle. So nipple areola, breast tissue, muscle, breast implant, rib. So my job is to make that horizontal incision and always be below the muscle. What do I do to the muscle? Nothing. Remember, if I'm making an up and down cut, I'm inevitably cutting to the muscle, right? So I'm going parallel and underneath the muscle, and that is all the bad tissue that I'm removing. Remember, in a normal human being, there's really not much there, right? There's not much fat there. So all that inflamed tissue is being removed because that feels abnormal, looks abnormal, and my sixth sense tells me that needs to go, and that is part of that capsule. Sometimes leaving that tissue behind leaves the badness behind, and as you have seen from my pathology reports, fat necrosis has been reported, histiocytic giant cell reaction, and remember, it's a silicone's leaching. Remember, volume is precious, especially in these many ladies who got implants because they were not, quote, big to begin with, right? So absolutely, there is no reason to remove any good, healthy, viable tissue because that tissue is volume for the patient. So there is no indication for removal of bad tissue. Now remember, as a surgeon, when I dissect, especially with my loupes and my headlights, I have 2 LED headlights, and my headlight on my head that I wear, I'm able to see clearly from my experience of having done a lot of surgeries as a board-certified general surgeon, taking care of a lot of, for example, gunshot wounds, necrotic wounds, whatnot else all over the body, leg, chest. I can tell what is healthy, what is viable, what is salvageable. Remember, in burn surgery, what is the rule? Remove all of the dead tissue, leave behind the tissue that might survive, because that in itself is tissue that can be salvaged. So very similar to, if you will, you have an explosion. The area directly around that explosion is bad. It is dead. It is not going to be salvaged. The area around is kind of a little bit, can be salvaged, cannot be. If the patient has bad nutrition, that area is going to go. If that patient has bad blood perfusion or low volume, is going to go. So the whole goal is to save all that volume, but not at the expense of hard, bad tissue. And all that good tissue needs to absolutely be left behind. And this is where that meticulous millimeter by millimeter dissection comes into play. And remember, I'm operating below the muscle. There's really nothing below the muscle. And as you will see, the tissue that is around, there's a lot of inflammation around. And you will see this in the pathology reports, chronic inflammation. Just another task or homework for you is to go look at the many pathology reports, and you'll see chronic inflammation, histiocytic reaction, giant cell reaction. That is all that tissue that's bad. That has to go. And you don't want to leave that behind. You don't want to be saying post-op, oh, I got a nice cosmetically looking breast, but guess what? I'm still hurting from the breast implant illness. Now, I will tell you, I will not dare remove any good, healthy, viable tissue, because remember, this is the whole expertise behind removing the bad and leaving the good tissue behind, because that is volume to the chest. Now, no other better example than the many ladies, for example, who have been actively nursing, for example, right? So they're basically breastfed their baby at 9 in the morning and 2 o'clock is their surgery. So later on the same night, guess what? They're nursing or pumping, and they're able to do that just fine because I never touch the breast tissue. I don't need to touch the breast tissue. Anyone who touches the breast tissue now will inevitably, especially like, say, for example, doing a a lot of dissection around the nipple areola is going to disrupt the nerves, the ducts, is going to leave a scar. And then, for example, someone is doing a self-monthly breast exam, and now all of a sudden she feels scar tissue. Is it scar tissue because of the suture that was used to put together? Now, some ladies absolutely will need a lift. Now, this is the pros and cons of doing a lift at the same time of an explant. Remember, the explant itself for me is 4 hours. You don't want to be doing what would be an unnecessary lift in the vast majority of the patients, well over 80. Now, there's a patient, for example, I did a consultation on this past Saturday. I looked at her pictures and I asked for them given her situation the way she described, and she absolutely is a candidate for a lift. And I gave her a code for a lift because I will tell you, no matter what I do, the excess skin that I remove from the sides, for example, she will still be a candidate for a lift given her presentation, period. And she has very bad scars from a previous lift type of an operation that she had that need to be absolutely removed because they are keloid and very wide and separated, and she had wound issues. So I'm going to go ahead and offer her that surgery because she's better off at the same time when I'm doing the surgery. And this is where I know I'm going to take more than the 4 hours. Last time I did a surgery very similar to this, took me almost 6.5 hours. So the point here is that the surgery is very well defined. The goal is to leave all good, healthy, viable tissue behind and remove only the bad that is by palpation hard, does not look good. Look at the many capsules that I have removed where there is silica inside because of the way when I go like this, you can see that the silica granulomas were present, or the fat is dusky and gray type. And so that tissue needs to go. God knows that could be fungus, right? So that tissue has to be removed because it does not look like healthy, viable, good tissue. So next question, why do my breasts swell up after I vacuum and mop? Now, that's a very good question. Now, remember, when you vacuum, you're primarily using the pectoralis muscle, which is the muscle on the chest that inserts into the upper arm, which is the humerus, right? So imagine I insert, and now if I start moving my arm, and now remember, vacuuming is a very strenuous activity where you're using primarily the pectoralis muscle, and you burn a lot of calories vacuuming. If you ask me what is one of the most strenuous activities that anyone can do post-op, vacuuming, all pectoralis function, riding a bicycle where you're putting your entire body's weight on your arms and then holding your entire upper body's weight on your arms, push-ups. This is all pectoralis function. Ladies, for example, where they have to lift heavy boxes. For example, one lady worked for Amazon. She had to lift heavy boxes. That's all pectoralis function, right? Because remember the insertions. So when you start overly using a muscle, and just like you sprain or strain your ankle, you're basically putting a lot of stress on that pec muscle that swells and gives you the illusion it's the breast tissue, but actually in reality it's the pectoralis muscle. And so the pec muscle is the muscle that is overly used, gets inflamed, angry, irritated. And this is where, remember, any lady who had the implants below truly could not use the pec muscle, because every time they would compress, i.e. contract the pectoralis major muscle, and then it would compress the implant against the ribs. So they would have this awkward feeling of bouncing the implants up and down, just like a male bodybuilder. When they go like this, they bounce the pec muscle up and down because it inserts into the upper arm. That's why the lady bodybuilder does not get her implants below. She gets them above the muscle because they don't want to compromise the muscle. So going back to your question, it is indeed what is the overusage of the pectoralis muscle. And for this reason, my post-op instructions specifically state, let's say if you had your surgery done today, you could brush your teeth because that's wrist. You could type text. If you have a desk job, you could be back at work 2 or 3 weeks because you're not doing anything other than moving your wrist and your digits, and you're keeping your elbows towards your flank. So you're less than 2-pound weight limit, along with the movement in the T-Rex position where you can wash your hair, you can drive once you're off the pain meds, you can relatively be independent, but you cannot reach for the upper counter. You cannot lift your baby that's 15 pounds, because that will inevitably using the pectoralis major muscle underneath which the implant was in vast over 95% of the patients. And now you're basically feeling the hurt. Now, my patients, I tell them around this week 6 mark. Now remember, I individualize each and every single patient. Week 6, week 7, week 8, I have them get 2-pound weights, and then I have them start flexing up and down gently. Remember, in the first 6 weeks, they have done passive recovery. Now at the week 6 mark, again, when I give the green light, I have my patients get some 2-pound weights and start flexing up and down, right and left, do the upper extremity gentle yoga exercises. So not only do they gently build on the pectoralis major muscle, but pec minor, pectoralis minor, latissimus, deltoid, serratus anterior, the suprainferior spinatus, the trapezium, all the muscles of the neck, shoulder. Now remember, when someone has implants on their anterior chest underneath the pec muscle, the pectoralis muscle is compromised. If you look at the shoulder, it's a very interesting tripod type of a structure, where anteriorly you have the pectoralis, on the side you have the deltoid, and then again the other muscle groups as well, the triceps and the biceps, but primarily if you lift your arm up, for example, and then on the back you got the muscle set as well. So they all kind of work, the 3 of them, as a tripod. If you compromise the pectoralis in the front, the neck, back, trapezium strain, plus all this gives you this fibromyalgia and this posture change because of the weight of the implant. Now once you start using the pec, which essentially, if you ask me, was free floating, right? Because underneath which was the implant, we need to let that pec settle down. Majority of the times it window shades up, and we need to let that muscle settle down. And once it settles over the 6 weeks, then I have my patients start gently working out and building the muscle like never before. And you will see these patients, when they train in the gym over the next several months, they're going to build this muscle mass and use their upper arms like never before. They'll be able to eventually, once they have built over the several months, the tennis and activities that require a lot of force, for example, golf, they're going to be able to do so with a lot more force and confidence because they have built the entire shoulder that was compromised because of the pec being compromised. The pectoralis major, if you Google, on Google Images, is a thick, big muscle that sits on the entire chest and is responsible for a lot of mechanical force along with the other collateral muscles that are involved in shoulder movement. Next question I just see, how do you identify a silent rupture in an MRI image? I'm needing medically necessary for help. Now, an MRI without contrast is the study of choice to look for linguini signs, among other signs, by a trained radiologist who will read if there is a rupture or not. Now, majority of the times, I do not know the number, this is accurate, but it is not 100% accurate because there have been times where I myself, I have operated. One Thursday I was operating, the MRI said the implant on the right is ruptured, and when I opened the capsule, believe it or not, the implant was intact. And the second patient, it said it is an intact implant, and lo and behold, it was ruptured. So the MRI has been accurate vast majority of the times, but it is not 100% accurate. So MRI is a good choice to get in those patients, for example, who have had first set of silicone implants, it got ruptured. Now there was free floating silicone, and then they got a second set. I want to look not for that second set that was ruptured or not. I want to make sure where those pockets of silicone are, so that when I do remove that implant and capsule that's current, I want to also remove that history of that silicone rupture and that all those residual silicone pockets that were left behind inevitably. Now, the next question, is above the muscle easier? Absolutely. Because remember, the pectoralis muscle is not touched. I removed the fascia of the pectoralis major and then directly underneath the breast tissue. So there is this very nice plane. The muscle is not touched. There is no dissection on top of the rib. And it is the best case scenario for me where I have to dissect above the muscle underneath the breast tissue. Next question. Let me go ahead and read some of the questions that were submitted. Now I'll be a little bit more precise as I answer. Can silicone particles left in the body create health problems? Absolutely. Silicone toxicity. This is all what is breast implant illness, right? This is the silicone leaching. The body is reacting, is on overdrive. It's in this hyperimmune phase. And now you're fatigued, just like when someone has a bad cold, for example. Now this is very anonymous. The silicone toxicity causes all these problems of what is the breast implant illness, and that is what you're seeing. And once all of this badness is removed, that is the implant, capsule, and all inflamed tissue sincerely, that's where the patient bounces back to a normal state of good health. Is it possible to do end bloc with polyurethane prosthesis? Absolutely. And the goal here is the surgeon has to go in committed, devoted, sincere, that the challenge is end bloc, end bloc, end bloc. You don't want to find out during the surgery that, oops, the capsule or it was violated and now there's free-floating silicone, because now your mandatory drains. Plus, I will tell you, no matter what you do, the silicone will stay in the chest no matter how much saline, 10 liters, 20 liters of saline you use, the drains you use. That just like slime, no matter what, how much you clean, it still lays behind. And you need small amount of silicone to cause the badness. You don't need a whole lot. Silicone was found in my spinal fluid that matched Dow Corning 200 injectable. We were always told the molecule was too large to cross the blood-brain barrier. Now, I'll tell you, look how many patients have brain fog, right? And fatigue. Now, I do not understand the physiology or I will not be surprised if there is inflammation, because it's present in every part of the body, that it would not cause the migraines, right? The brain fog. What is the physiology? I'll not be surprised. It's basically because it travels in the brain. My lumbar puncture proved them wrong. Do you believe there is association concerning neurocognitive problems and the silicone? Absolutely. This is the brain fog, right? Very common. One way to gauge and see, look how many young ladies. I've had so many young patients. For example, one young lady, she was doing her exam, her board exam, and she's like, I cannot think. I look back just a week ago, I wrote down notes with my own handwriting, and I cannot even remember and recall whatever I just wrote. So I need to get an explant in order to pass my boards. And believe it or not, these are young ladies. And I have a 75-year-old lady. The whole family was saying she's got Alzheimer's, she's old, she's just 75 years of age, as you can imagine. And she said, I know better. And her kids were taunting her, sorry to be blunt. And these are her words. She used that. And they were telling her, Mom, you're 75, and she knew better. And believe it or not, you will see her Facebook Live that I did with bilateral rupture implants, and she did amazingly well. And she knew better in her heart that there was an inherent problem with her implants. Next question. On your most challenging days, Dr. Khan, what's the one thing that keeps you in the fight for all the women? Now, I will tell you, this is something from the very beginning. I remember this vividly. One of the Allergan reps came over when I was a fellow, and he's like, sign here, you will get the Botox, you will get the fillers, you get your implants, you will have an account with us. And I said, I'm not going to fill one out. And most of my fellows, friends, they were like, what are you trying to do? You're not going to do augmentation? I said, no, I'm not going to do something that I don't believe in. Now, I will tell you, it is extremely rewarding and humbling for me that I chose not to augment. I choose not to augment, and that it is very humbling for me. Just like each and every one of you will help someone and feel great about it, right? And in a very selfish way, but in a very positive way. What makes it even more humbling is the fact that the whole world is looking at me and saying that I'm like making this up. I say to the rest of the plastic surgeons, to the emergency room doctors, rheumatologists, primary care doctors, to the rest of the significant others who question and I don't blame them, right? That what I'm doing is not making things up. I am telling you what the FDA has said, what the manufacturers are saying, and most importantly, what the ladies are saying. And to be able to do what 99% of the plastic surgeons are saying not, and to be able to do something that the whole system is saying is incorrect, and to help the many ladies, it is extremely rewarding, and I couldn't be happier. I couldn't be more humbled. One of my pathology friends, he's the MD PhD who was a guest with me. He told me he's on the private breast implant illness support group page. He said he runs into a lot of doctors, colorectal surgeons, oncologists, other doctors as a pathologist. He said, I have never met a group of patients that are this sincere, motivated, dedicated, and supportive of a doc. As a pathologist, as you can imagine, he does not even see patients, and so you can imagine how he's the other spectrum, right? He does only autopsies, if you will. And so he was telling me at the physician lounge one day that it must be, I said, it is the greatest feeling. And this is where, it is priceless. I have patients who commit to me without even talking to me. They pay for their surgery. They book the date with Jennifer, and they have not even seen me. And it's very humbling to talk to them because they have full confidence in someone they have not even met or talked to other than these Facebook awareness. And I will tell you, I am honored to have a practice where I can discuss and share from my heart. And I will tell you, it is better than any other feeling on earth, where every day when I get up, I work almost 100 to 120 hours a week. This past Sunday, I was up till 2 in the morning. Last night I was up very late, till approximately 12:40. And I will tell you, it doesn't even feel like work, because whenever I talk to, and the patients know this, that's the beauty of the whole thing. I know each and every single of my patients. My patients tell me I've never talked to a doctor this long ever in the many hospital visits, doctor visits. What's even more interesting, I have a lot of nurses as my patients. If you look at the number of nurses that have come to me over the years, that it is basically very, very, humbling to say that they understand medicine. I will tell you, better than anyone else, they understands the patients better than anyone else, because they're taking care of the patients, right? As doctors, we talk to the nurses because they're always by the bedside, and they know what is the right and what is the wrong answer and what is a political answer. And this is where, even right now, we're very assertively, very confidently, and very convincingly saying and discussing what are hard facts. These are not my opinions. Trust me, I would be better off financially, as I've stated, and I don't want to say it, it does not sound right. I would be 3 times richer, and a lot more pleasant surgery. So today's case that I did, the 47-year-old, she is the one who had the heart attack at age 40, and it was given her history. I had to do her at the hospital. My assistant, she had her fingers and a spasm, and her neck was hurting, and I said, yep, that's what it takes to do the surgery. And I'll tell you, I'm very humbled to say that I can do all of that, and it gives me great pleasure. One patient at a time, and one implant at a time. One side may be easy, the other one might be twice as hard, for example. And it is literally a honorable experience for me to bond with patients from all over the United States and all over the world. We have, I believe, a question from a lady from Italy, and again, another patient from last time that we talked to from South Africa. So it's very humbling. So what I'm going to do now is I'm going to go ahead and I'm going to start reading questions, and hopefully I will answer as best as I can. If you again have any questions, I will be more than happy to answer. As I just want to mention, I don't like Facebook, social media, TikTok, Instagram. I'm old-fashioned. My staff does an amazing job telling me what are the questions I need to answer, and so thank you very much. So as I answer, so you have to have the confidence in your surgeon. In a topic like this today, your job is not to make a decision. Your job is, right now, you're on a listening tour. You want to listen, talk to not only me, talk to 2, 3, 4, 5 other plastic surgeons, so that you get the confidence and the determination that your surgeon is going to do the right thing. So I'm just scrolling up and down the questions. So I have had implants for 38, it says hours. I have had implants for 38 hours. 7 years ago, I was diagnosed with CLL, SLL. Could the implants have caused the cancer? Now, I'll tell you, you have to go to a medical oncologist. They have to do the CD30 staining. The BII ALCL is a very defined, well-studied, and the medical oncologist would be the one at a major reputable institution like MD Anderson or the Cleveland Clinic who would be able to better answer that question. Unfortunately, I would not be able to answer that question. So are there more challenges and or complications for mastectomy patients with textured implants? So remember, textured implants definitely cause more inflammation from my experience. Even smooth saline implants have inflammation, but textured implants in general, that's why they've been banned. Now, mastectomy patients, remember, they don't have any breast tissue, so their implants normally in general are much bigger, 600, 700, 800, depending on the chest width. Majority of the times, alloderm is used. Sometimes there's clips, metal clips, and suture material that's used. And I have to do a flat chest closure. So on average, those patients are, relatively speaking, more involved. I take 5 hours. I do them on a Wednesday or a 2-day surgery day so that, you know, my staff is not there late and whatever length of time it takes, because those are certainly much more involved than, let's say, a 325cc implant on a mid-35-year-old lady for cosmetic reasons. Remember, some of the mastectomy patients, if they have radiation, that's a big challenge because the skin gets very thick and fibrous, the blood supply, nerve supply is altered, and the tissue itself is damaged, and so that is compromised skin to begin with. That's much more involved, especially some of the ladies. Last time I did one was a lady with bilateral right and left latissimus flap. I have done patients with deep flaps. These are mastectomy patients, which is the deep inferior epigastric perforator flap. These are very involved cases compared to the other ladies for cosmetic reasons. So the next question is, I have lumps under my arm. Now, I will tell you, whenever you have a lump under our arm in a patient with breast tissue, you have to always think cancer. This is exactly 8 days ago on a Tuesday. I had a patient that was supposed to be coming from Florida. She had a lump, and believe it or not, that lump turned out to be breast cancer, and we had to cancel the case. So any lump, remember, 1 out of 8 or 9 women are going to get breast cancer. You want to get those lumps checked. I want to also highlight today, one of my very, very close and dear friends ended up getting stage 4 colon cancer. Now remember, colonoscopy initially was age 50, and now they're recommending age 45. Remember, it's the number 3 killer. So any lady, you have to get a mammogram. Millions of patients have had breast cancer diagnosed early because of mammograms. And millions of lives have been saved all over the world because of colonoscopy. So these are very important screening tools because we don't want to find out when it's too late. Look, this friend of mine, stage 4 colon cancer to the liver. You know, he's getting chemotherapy and he's already lost 18 pounds. He does not, you know, God bless his soul. Hopefully he's able to fight this. Just like with breast cancer, 1 out of 8 or 9 women are going to get breast cancer. We do not want to find. You want to do the BRCA gene. If you have a first degree family relative, you can talk to your doctor about the BRCA gene testing. If you have a strong family history, appropriate screening with mammogram and or ultrasound and possibly MRIs. Again, this is all to be determined by your primary. So do not be, a thermogram is not the answer for screening for breast cancer. My breathing is bad. I feel like I have asthma. So again, it's very typical. I want you to go ahead and get checked. Maybe you might have asthma and you will get an inhaler and you might get treated very effectively. So by all means, go ahead and get checked for asthma. And this is where your primary care doctor comes in. Next question here is, I have been diagnosed with this chemical sensitivity This is primarily an overlooked complication and misdiagnosed as anxiety provoked. I will tell you, this is, again, Melissa, God bless you. You've been wonderful. And, I'm very happy how you are truly a leader in this world of explantation and helping the many ladies kind of understand and getting that informed consent. I believe that was more a comment than a question. Next question. So the insurances are, why will the insurances pay for these medical devices to put into our bodies, but once they make us sick, then it's on us? This is unfortunately the corruption of medical insurance. This is, I was surprised to hear if someone has breast cancer, that cancer side is covered, and by law, the other normal side is also covered equally, as if that side had cancer. Nowadays, the insurance companies are saying, well, that side is on you. If you ask me, that is wrong, and I say to you, write to the insurance, write to your, you will never win with the insurance. The insurances are like a big mafia, unfortunately. They have no purpose, no vested interest, just like any other insurance company, but to compromise the doctors, compromise the hospitals, compromise ultimately the patients. Look at how much the deductible is, right? $6,000, $10,000 normal, right? And this is not fair. Look, we just went through midterm elections. Look, the presidential election is coming, and just like that, everyone is going to not even debate this question, but 5 minutes, and it's going to be over. It is certainly compromising the health of the patients and overall disrupting the quality of life. Next question is, I am going to look... so let me go ahead and say... So now, next question, can breast implant illness cause inflammation, changes in color and temperature of legs and hands? So yes, so I want you to go ahead and, so this is a autoimmune phenomenon. This is a phenomenon where rheumatological problems such as scleroderma, rheumatoid arthritis, or lupus type symptoms are basically presented, where look at the patients go to 1, 2, 3, 4, 5 rheumatologists, and they say, well, you don't have lupus rheumatoid, but they have what is Raynaud's phenomenon. Look at the 22-year-old lady, right? I mentioned earlier, 2 weeks into her augmentation, she had tingling numbness. Now, don't listen to me, listen to the many patients. You will hear each one of them say the vast majority, they have tingling numbness in the arms and legs, and cold, discolored hands and feet. Now they go to a neurologist. They say, well, the EMG is unremarkable, the exam is unremarkable, and this is the inflammation close to the vessels, i.e. the vasculitis, and this is also the nerve inflammation, irritation that occurs that causes this tingling numbness. And you will hear the many patients that will state clearly that how their symptoms improve. Now, I don't guarantee to any of them that, these are the symptoms and how they're going to improve. Sometimes they may have sciatica, for example, lower extremity. Sometimes they may have underlying Raynaud's phenomenon, for example. A lot of ladies have, issues, for example, with vasculitis, for example, for many other reasons, and they may not have implants, for example. These are the same group of patients, but certainly I want you to go ahead and look at, so this is important. If you have, let's look at a hard fact again. If you look at the MD Anderson paper, Dr. Clements out of the MD Anderson Center, now this was a study of studies. They looked at 100,000 patients. I'll have this up on the Facebook. 80,000 patients with silicone implants, 20,000 with saline. And they said that patients who had implants, silicone implants, they had a 8-fold increase of what is Sjogren's disease, which is dryness of the eyes, 7 times scleroderma, which is a connective tissue disorder of the hands primarily, and then 6-time likelihood higher risk of what is rheumatoid arthritis. Now, this is not a coincidence. This is the hallmark feature of the rheumatological joint problems, right? Autoimmune type issues and lupus/rheumatoid type symptoms. This is where you have compromised, small vessels like the vasculitis that cause this temperature and color changes that are very prevalent, including the rashes that occur. If you look at the many ladies, from my observation, I have noticed that a lot of ladies have these cherry red spots. These are the hemangiomas. This is the inflammation that's present. Next question I had 2 different surgeons remove silicone from me after having a silicone gummy bear implant ruptured. I still feel sick. And they were put in 2015 and taken out 2017. So this is very interesting that you had a rupture in 2 years. So this is very likely what occurred at the time of surgery, which was a technical issue, very likely when your surgery was done, because it's unusual for implants to rupture that early, but they can occur. Remember, the FDA and the manufacturers themselves will tell you that the MRI needs to be done at year 3, and then every 2 years they're onward to look for what is a silent rupture. Now, I will tell you, these 2 surgeons, and with all professionalism, how committed were they to removing the whole capsule? So in your case, this is what I would do. I would get an MRI with and without contrast just to identify what are silicone granulomas or pockets that might have formed where the silicone did rupture, but it was incomplete to remove, because you're still having these symptoms. Now, I want to make sure, this is where I do the questionnaire, what are the symptoms of breast implant illness that you have? What are the medications you're on if you have underlying rheumatoid arthritis and amongst all these other problems? Now, once I know, I would get your operative record from those 2 surgeons and see, was there an active spill? And then I would get an MRI with and without contrast to look for the silicone mastitis, silicone granulomas, pockets of silicone that are very likely left behind till proven otherwise. Was all the capsule removed? And what was the pathology of that tissue? What was that removed? Is there fat necrosis, whatnot else? Now, in your case, once I do an evaluation, I would then determine, given your feedback, your option would be do nothing, right? You feel the sickness. Now, sometimes if you go to a doctor, they'll give you a steroid that might put out like the fire for a little bit. But in your case, going back in, and again, after having read the MRI report and possibly seen the MRI itself, number 2, seeing the operative record from your surgeon who removed the ruptured implant, exactly what he did, how long was the case, I look at the time in, time out, and then looking at your symptoms, then I will make a determination. Well, no guarantees will be made. I will guarantee one thing. I will make an incision horizontal. I will go, and once I know where this implant was, if it was below, above, if there's any pockets, if there's any... Now, this is kind of going back to that first question. Any inflamed tissue, any bad tissue that looks even remotely suspicious, I will remove. I will remove the whole capsule off of the rib. Very likely your surgeon left the capsule behind on top of the rib. I will remove all and bad inflamed fat tissue, and I will send that off to pathology, and at the time of the surgery, with full confidence, I will know exactly what was the culprit and if this was the problem or not. And then post-op, I will then, and we will wait and see for 2 things. Number 1, if what does the pathology report say, and most importantly, we will hear directly from you, and it will be like kind of black and white, as to what improvement did you seek after your explantation because of the history of the rupture. I will also, sometimes I like to ask, again, with how committed your surgeon is into removing the whole ruptured silicone, and did you have drains, things like that. And I'll go into a lot of detail. Again, knowing exactly, just like in this patient that I'm going to do on the 12th of April, where her surgeon removed the entire implant capsule, but guess what? She has capsule remaining behind, right? Or look at this other case where this lady that I did 2 weeks ago, and I'll do a short video. She had a set of implants. The one on the right ruptured. So she goes now in 2005, gets an MRI, it shows rupture. In 2006, the surgeon removes the implant as best as he can. Now some of the ruptured implant is kind of there at the bottom, and he puts in another set of fresh implants in 2006. Now the implant that I removed in 2006 was intact along with the capsule. Now the task was not done. The task was for me to remove that silicone pockets, one at 2 o'clock, another one at 7 o'clock, and another one at the bottom. I removed pretty much most of the tissue at the bottom where the silicone had gravitated down. Because of silicone being dense, it just gravitates down to the lower part of the chest. And lo and behold, we have a pathology report that clearly states, and in the Facebook Live, I cut through this tissue that was abnormal, and when I went like this, you saw that gum sign where this was indeed what was ruptured silicone from before. And so this was very important for me to get the MRI and kind of put the whole case together to show that, okay, remember the MRI sometimes will not show these pockets, but it is important for me to identify the pockets of the residual silicones, the residual silicone, and the residual capsules may not be seen. Now what I'm going to do is I'm going to go ahead and what if the post-op pathology shows fungal? Then I refer you to an infectious disease doctor who will then look at the fungus report. Remember, they will have it growing on a petri dish so they can find out what is the antibiotics that they're sensitive to. They might then, so in my cases where 3 patients, for example, that I do remember had positive fungal, I send them to infectious disease. The last patient was treated for 8 months with antifungal therapy. And this is, again, the symptoms that now, remember, it's relatively rare, but till it's ruled out. Now, I just want to mention, there's kind of 3 checks and balances. Me, sometimes, grossly, I can tell it looks dark, dusky. It does not look healthy, just like you would see fungus on a bread. Now, this is very crude, but the other 2 ways are very defined. When the pathologist looks at the capsule, remember, if there's fungus on the implant, it will be inevitably present on the capsule. So when the pathologist looks at the capsule, he or she will identify the hyphae that we know from grade 6, those branch-like structures of the fungus. And he, the MD pathologist, will say, well, I see fungus. Just like we saw in our microscopes when we were in grade 6, 7, 8, right? And number 3, the most important, I do fungal cultures on all my patients, and that will tell us if there is fungus or not. So some patients that I talk to, they say, well, I have fungemia, I have fungal infection. I said, well, do you have a clear infectious disease doctor, not a functional medicine doctor, an infectious disease doctor that shows has grown and speciated on your lungs, done a bronchoscope to pull out tissue, or what they call the bronchoalveolar lavage, which is basically they take the fluid and then they look for fungus from within, for example. Now, there are many reasons. You could go into a house that has mold and you could get a fungal infection in your lungs, and that might make you think, well, I have a breast implant associated fungal. No, when you do the capsules and you're doing cultures, then that is a very clear test that this is not fungus, and that puts to rest any fungal questions. So I leave it up to the infectious disease doctor. I'm not an infectious disease doc. To treat fungus is very, very challenging. I had a patient that I took care of, was using a wheelbarrow, and he pushed the wheelbarrow, and it was a wooden handle. That sliver of wood went into his skin and caused a very bad hand infection. It turns out it was a very rare, very strong fungal infection, and infectious disease was on board to treat the patient for months. Given the fungal infection within the hand and the delicate structures of the hand. So So is it possible for a woman with prior tuberous breast deformity to go back to a regular shaped breast after explant? Now, I will tell you, remember the tuberous breast, the surgeon has to score the breast tissue so it splays open, and that ring essentially opens out such that the tuberous deformity is no more. And this is a relatively common, unfortunate problem in ladies. Now, removal of the implant is one problem. Tuberous breast deformity correction is another problem. Now, sometimes that's done incorrectly, or that's done just so that the implant will coat mask that. The goal here is to remove the implant capsule and then waiting and seeing once the inflammation subsides to going in. Remember, majority of the implants are placed below the muscle. Going into the breast tissue to score that breast parenchyma is a separate surgery in itself. You don't want to be doing those two surgeries. Usually the surgeon, a good board certified surgeon, it's an easily correctable problem, the tuberous breast deformity, and you're under the assumption that that would have been addressed first, and then the implants usually are placed in those patients by the surgeon. So that correction absolutely can be made. Remember, plastic surgeons, half of what is plastic surgery, if not more, is breast surgery, right? And so this is an easily correctable problem by a good, reputable, board-certified plastic surgeon. A lot of patients are born with Poland syndrome. A lot of patients with hypomastia, which is inadequate development of the breast tissue where there's asymmetry, and for that reason implants are placed, amongst many other reasons, sometimes trauma, sometimes lumpectomy, partial mastectomy, and implants are placed. So a lot of quote symmetry operations can be done later on as needed. I'm going to go ahead and answer one more question, and with that I am going to go ahead and wrap this up. Hopefully we'll have one of these. So do a lot of women have bloating as a symptom of the breast implant illness? Now, I will tell you, the GI tract absolutely is very much negatively affected. Just listen to the many ladies. Some ladies cannot tolerate ice cream or cheese or food. Just the smell of the food kind of irritates them. They lose weight, for example, or they gain weight because of the inflammation. Now, patients have irritable bowel syndrome. As you can imagine, all these other organ systems are affected, and certainly the GI tract, which is all the way from the mouth all the way down to the bottom, where you have gastritis, reflux, amongst the many other problems. Now, around the time of the surgery, my patients can get that when they get the antibiotics, especially for the 7-day course. Now, you can get that, let's say, if you get a pneumonia or upper respiratory infection, or, you take the antibiotics, that will always disturb the GI tract. Any antibiotic will disturb the GI tract. But remember, at the time of surgery, we want to make sure, remember, this is an inflamed area and a big area that the dissection is occurring. I don't want an infection, and thank God to date, I'm happy to report I do not have any active infections, any infections where the cellulitis or pus was removed, and I'm very happy to state that. And so the pain medications, all of them cause nausea, vomiting / GI distress. They slow down the gut essentially, right? Norco / or Percocets, if I do prescribe, they cause constipation. So I tell my patients the day after surgery walk. It helps keep the gut going. Lots of fruits, vegetables, lots of water, and hopefully with the regular bowel movements, if anything, you continue to be on top of the constipation, just like on top of the pain, and you're not chasing the constipation, you're on top of the constipation, and that will help certainly with the bloating. I have seen this in 2 of my patients, unfortunately, who decided on their own to not take the antibiotics because they were just not comfortable, and I don't recommend that at all. And they did not take any pain meds. They still got bloating. Now, I'll tell you, after the 24 hours, the anesthesia meds are all gone, easily, within the first 6 to 10 hours, if not 24 hours for certainty, right? And I will tell you, there is a post-op phenomenon that affects the GI. How much of it is BII, how much of it is the perioperative, but entirely, certainly, the GI tract is certainly very much affected, and we will see over time how that can be addressed. Again, by, just good food. Remember, you are what you eat. Good food, organic food is the way. Nothing processed. Now, going back to the colon cancer, but again, this is true. Eating the berries, for example, fruits and vegetables, nothing meat. Again, I'm not a vegan, but I will tell you that almost everything is basically, if it has to be organic that you take, because everything has chemicals in it and they're all additive. It is only healthy to eat good quality product and not processed meat, processed food. And so that certainly will help with the bloating as well. Now remember, a lot of problems in the United States from what is a fatty liver, the most common reason being fatty food consumption. So very important to be eating lean, healthy, and smart. So having said this, what I'm going to do is, it's 8:44. Hopefully you found this informative. One day I ran into an old friend of mine, and he said, I decided that I was going to watch what you were going to say from the beginning to the end. And he told me, you did not even sip water. You kept talking, and I'm surprised you can talk this much. And I say, I could easily talk another hour. This is something where, I have no idea. I've been here for almost an hour and 40 minutes. I really, really enjoy my work. I'm blessed to have a wonderful career where I help so many ladies. I connect with so many ladies. Please share this information. I have no ill will against anyone. All what I want to do is spread good, do no harm, help the many ladies who are hurting. Look, we have a whole track record of how many patients. If anything, I will end with this on my end. One of my very close friends who's a plastic surgeon, he called me up one day, he told me, Khan, I'm afraid for you. He said, well, what you're doing is very exaggerated and very extreme. That was the word. And I said, why do you say that? He's like, look, you're doing Facebook Lives on a topic that's very controversial. The whole world is negating it. Everyone is against you. I have had anesthesiologists amongst general surgeons, among orthopedic surgeons, my colleagues. It's like, what are you trying to do? Swim against the current. And I said, if you think about it, all what I'm doing is, number one, removing the implant, and I'm removing the capsule, right? And the inflamed tissue that's around the periphery, and that is shown to be involved with that multinucleated giant cell reaction. And that's it. And if you will, the patients are getting better, they're healthier, they're happy, and the pathology is telling us the giant cell, the badness, the histocytic reaction, the inflammation, chronic inflammation, the silica, right, within the capsules. And then you will see the BII. You will not know. Look, there was another report that Tracy Gary told me about. A patient had an explant done, and then the surgeon decided to put another set of implants. And because the tissue looked abnormal, it turns out that the patient had BII. Now the patient has to remove the implant, has to undergo a residual capsulectomy. And look, the many patients who have had incomplete capsule removals, they have to go back to get their health back. And so all what I'm doing is, I'm very transparent. I'm discussing a topic that is slowly. Remember, when I started discussing this, there was no FDA warning, black box warning. There was no awareness, right? I remember when I started my career, I chose not to augment purposefully. Augmentation is so easy. Dermatologists, OBGYN, general surgeons right here in town, ENT doctors are doing it, right? I chose not to do what most of my plastic surgeons do, and this is the gist of their practice that is the most financially rewarding. In an hour, you can put in a set of implants and make a lot of money. Now, I am seeing exactly the fruits, the thoughts, and what I knew firm in my mind, because I saw these patients over the years, right? And the point I'm trying to make here is, do no harm, and I'm blessed and honored to talk from my heart and to help the many ladies who are hurting. And not only them, their significant others, their kids, their neighbors, their job, the productivity. And what we're trying to do here is raise awareness. And I'll tell you, there is a day that's going to come, hopefully very soon, where the implants are going to be banned, and hopefully this time around saline implants too, and that we can put a permanent ban on what are, basically implants that do not belong in the human body. period. And as simple as that. And anyone who has listened to what I'm saying, who has been basically non-biased, will agree that these are dangerous devices. They're associated with death. They're associated with lymphoma. Certainly that number is very low, but not, this is quote underreported. They're not safe. They're only replete with problems, and they have a certain life. Sometimes, look, this lady, her rupture occurred in 2 years, right? Look at the misery that she's going through from 2017 till now, right? Look at the many other ladies who are hurting. Some patients who get breast cancer, and they're still now hit with another type of bad, i.e. silicone implants or saline implants, and they have to go through the misery of removing them. So the point here is, it's a pleasure and joy for me to discuss what is a very defined topic. Yes, it is relatively complex, but if you follow along with me on the private breast implant illness support group page and then the web page, and I say to you, listen to the patients, you'll only be convinced without a doubt that explantation is the right choice and the sound choice, and you will have peace and happiness and no health worries later. This is Dr. Khan, Executive Plastic Surgery.